Hi, I'm Karl Kwok, an interventional gastroenterologist at Kaiser Permanente Los Angeles Medical Center, and I serve on the ASGE Quality Assurance and Endoscopy Committee. I'm honored to talk to you today about our group's work on the impact of direct oral anticoagulants on the risk of post-procedural bleeding and thromboembolic events in the setting of elective endoscopies. In an average year, over 18 million endoscopies are performed in the United States. And increasingly, more and more patients are being prescribed these agents of direct oral anticoagulants coming through the GI lab. Some initial studies demonstrated an increased risk of GI bleeding from dabigatran versus warfarin, while more recent studies have demonstrated the direct opposite of increased risk of GI bleeding from warfarin versus the DOAC class of medicines. Partially as a result, many practicing gastroenterologists are unsure of the risk of GI bleeding from the DOAC class of medicines in the periprocedural setting. Thus, the aim of our group study is to look at the risk of post-procedural GI bleeding and thromboembolic events from the DOAC versus the warfarin class of medicines across a diverse patient population in a large US-based integrated healthcare organization. We performed a retrospective cohort study of patients aged 18 years of age and older coming into our GI lab for an elective outpatient procedure that were prescribed either a DOAC class of medicine or warfarin, and compared the relative risks of bleeding and thrombosis within 30 days post-procedure. We performed both univariate and multivariate logistic regression analysis to compare the two groups. On univariate analysis, there was no difference between DOAC and warfarin groups in terms of lower GI bleeding in the elective colonoscopy cohort. There was a higher risk of upper GI bleeding between the DOAC and the warfarin groups in the elective EGD cohort in subgroup analysis. Additionally, we detected approximately twofold increase risk of GI bleeding in the therapeutic EGD and colonoscopy group compared to the diagnostic EGD and colonoscopy group. For thromboembolic risk, we found no difference between the DOAC and warfarin groups in elective EGD or colonoscopy patients. We did, however, observe a twofold increased risk of thromboembolism in the therapeutic EGD versus diagnostic EGD group. We did not detect a difference between the diagnostic and therapeutic colonoscopy groups in terms of thromboembolic risk. With regards to mean time to event, there was a trend to sooner time to event of GI bleeding in the DOAC group versus the warfarin group. There was no apparent difference for mean time to event for thromboembolism between the two groups. On multivariate analysis, there was a difference between the DOAC and the warfarin group for upper GI bleeding across both diagnostic and therapeutic EGDs. There was no apparent difference, however, between the DOAC and the warfarin groups across diagnostic and therapeutic colonoscopies. In conclusion, for the DOAC group, we found that therapeutic EGDs and colonoscopies had approximately twofold increased risk in GI bleeding or thromboembolic events. Diagnostic EGDs were also observed to have an increased risk of upper GI bleeding. However, diagnostic EGDs were not shown to have an increased risk of thromboembolic events, and furthermore, diagnostic colonoscopies did not show any evidence of increased risk of GI bleeding or thromboembolic events. We would like to thank the editors of GIE for this opportunity to present our work in a video summary fashion, and encourage the viewers to read the original article in Gastrointestinal Endoscopy. Thanks so much for watching.